Hello, future RNs. I'm going to get started on Unit 5, do a quick overview of bipolar and their related disorders and depression. As always, I apologize now for my heathen children. I've tried to bribe them, but who knows what will happen. So bipolar 1 is what we think of when we think of bipolar. This is extreme mania. And mania starts off kind of happy, energized, you're not eating, I have all this energy, my house is so clean, I can get all my work done in no time. And then 1, from lack of sleep, and 2, just from the process of mania, psychosis happens. Disturbed thoughts, agitation, exhaustion, and depression. Combining agitation and depression is never a good thing. And that mania, when it ends, it leads way into a major depressive disorder episode. So these patients, right, go from baseline. You have baseline here, and they go from baseline, and they go to the highest high and the lowest low. And they go back and forth. This would just keep repeating. Bipolar 2, I apologize for getting off track. That was a record that it only took 1 minute and 17 seconds for my kids to bother me. So bipolar 2, we don't often see many patients hospitalized with bipolar 2 because it's not severe enough to cause that marked impairment in functioning. There's no psychotic features. They don't often wind up hospitalized. And they have hypomania. So they have increased energy. But this is like your fun friend who is always ready to go on a road trip. They know the best bars. You can go out with them and have the best time in your life. They have some racing thoughts. They have some flight of ideas. And they're talkative. But the pressured speech is not the same. So in bipolar 2, this mania curve, it only goes part of the way up. They still deal with depression, and honestly, sometimes they don't go to major depression. But you see the both, and bipolar 2 is that hypomania. So when you compare bipolar 1 to bipolar 2, the big difference is bipolar 1 goes all the way up to the top for mania, and you tend to have psychotic symptoms. Bipolar 2, they don't get the psychotic symptoms. It doesn't affect their life. They're just super cool. This is your super awesome friend. So when we think about what is mania versus what is hypomania, mania, they'll go days without sleeping. They're super euphoric. And sometimes they're treatment resistant because some patients think that mania is their drug. They're going to push limits. They're going to be going 180 miles down the road, right? The words, we watched that video, and that guy, it was like the words just could not stop coming out of his mouth. You're going from topic to topic. It's almost uncomfortable to be near these patients. And then they get utterly exhausted. They think they can do anything. I can drive from New York to California without sleeping. And they go and drive from New York to California in one trip just because. Grandiose, right? They often are wearing over-the-top clothes. But then they go into depression, and when they go into that major depressive episode, you see the suicide risk. Through here, it's less suicide and more danger to self. Hypomania, right? It's a lot of social interactions, life of the party, spending tons of money, having a lot of sex. And it's not causing enough to be hospitalized. Here is our friend. I'm not going to play it. He was the one with that pressured speech, and the psychiatrist could not get a word in. She called that Greyhound bus, and she was just kind of flighty and fidgety, kind of weird laughter. She slept like 3 hours and then was like, let's go. Cyclothymia is hypomania with a mild depression. And this kind of just alternates back and forth, and these patients just cycle, why we call it cyclothymia or cyclothymic disorder. And they just alternate back and forth between the two. So what do we think of when we assess these patients? What are their mood? Are they super euphoric? Are they agitated? Are they uninhibited, right? Are they doing crazy things? Are the moods changes quickly? Are they unstable? Is it hypomania or mania? What about the thought process? Pressured speech is word vomiting, right? Circumstantial, tangential, and loose all kind of connect. And they kind of go from topic to topic, and you can kind of follow the train of thought. And then they get back to the point. Or is it flight of ideas? They are going from topic to topic to topic to topic, and they never connect. You have no idea. You cannot follow the conversation, and you just get lost in seconds. Clang associations is the rhyming. We saw this also with schizophrenia. Click, clack, clutch, close, rack, have a Big Mac. I don't know. All sorts of just rhyming. Everything they say rhymes. Not seen with bipolar, but other types of speech. Maybe they have neologisms. They're making up words, talking in tongues. Maybe it's word salad, a jumble of words. You never know. Thought content could be grandiose. They think they're the best, right? I invented the electric car. Elon Musk stole the ideas from me. I can't believe he did that. Persecutory. Elon Musk is out to get me. He's trying to kill me. We have to look at the overall cognitive functioning, right? There are plenty of individuals with bipolar who have it under control, who are healthcare professionals, lawyers, all sorts of stuff. However, when it gets out of control and the more manic episodes, the more permanent cognitive deficits that we see. Guidelines that we have to look out for: danger to self or others. Are they bipolar and getting in fights because they're manic? Are they depressed and they're suicidal? Or are they just doing things that are dangerous? And honestly, at the base, when we're talking about danger to self, we have to watch out. Are they a fall risk? Are they manic and they're pacing back and forth and there's a commotion and they're at risk of tripping over something on the unit? Protection, what's their medical status? If they're not eating and if they're not drinking and not sleeping, regardless of their psychiatric status, we have to address that first. We have to get the patients to a very good physical state before we can address their mental state. So we need to give them food. We need to give them water. Is it finger foods, right? Is it an Ensure? Is it every time they come up for meds, we're like, drink this full cup of water? And we have to get their family involved. Family needs to know what's going on. There might not be anything they can do, but we need to get the patient support. How do we approach these patients? We need to be calm. If you go up to someone mania and you're like puffing your chest, ready to go, you're just going to get yourself in a fight. We need low stimuli and we need structure. We have to redirect aggressive behavior. We cannot, like if you have someone like pacing up and down, you can't restrain that patient. You have to verbally de-escalate. We have to make sure harmful objects are gone. Monitor INO and vitals, lots and lots of finger foods, protein drinks, bottles of water floating around for these patients. We got to get them to sleep. If they turn around and you find them fall asleep on the floor, you leave them there. You skip vital signs. You do not wake them up for vitals if they're sleeping. You just let them sleep. Watch their clothing choices and make sure they're going to the bathroom. Make sure they're eating okay. So what do we do for meds? For agitation in these patients, right, we're going to do that B52. We're going to add in an antipsychotic. Mood stabilization, lithium, and our anticonvulsants. And in bipolar depression, we never give an antidepressant because that increases serotonin and it takes them from that low serotonin of depression to the high serotonin of hypomania. So we can cause them to go from one side of this to another. Well, the mood stabilizer, the whole goal is to get them into the middle. So what do we know about lithium? We've talked about lithium before, right? It stabilizes the mood. It reduces those mania symptoms. Level is somewhere, give or take, between 0.5 and 1.5. I've seen it 0.6 to 1.2. Regardless, your early signs of toxicity tend to start above at 1.5 or above. And those early signs of toxicity are a lot of that GI upset, right? Small tremors. Severe signs of toxicity, those advanced, that ataxia, the EKG, the clonus, the seizures. And honestly, grand mal seizures, coma, and death are your severe toxicity. So what do we got to teach our patients and what do we need to know? This isn't something you're going to get addicted to. This is long-term treatment. Patients need to stay on these medications for life. Sodium affects lithium levels. So we have to watch what we're eating, and we have to watch fluid intake. If you drink a lot of water, we are decreasing our lithium level. If you have diarrhea, vomiting, excessive sweating, that leads to dehydration, and that increases the lithium level, and we need to call the doctor and get a stat level, right? Because we don't know where they are. At the same token, diarrhea, vomiting could be some of the earlier signs of a lithium toxicity. So it's doubly important to make sure we're looking out for those and letting the patients know you have to contact us if that happens. Same token, if you have a patient, right, if we're looking at a 1.5 is where the highest we want the level, and your patient gets some labs back and it's 1.6 and they're not feeling too good, we might hold that dose and push fluids while we wait to get back to the doctor. Because pushing fluids will help lower that lithium level, and it's a really easy nursing intervention that we can do. Anticonvulsants. We've talked about these before. Y'all should be familiar with these from pharmacology and your non-psych classes. But, right, Depakote, Tegretol, Lamictal, those are all things that we use. We have to watch out for liver functions. We have to watch out for an increased risk of Stevens-Johnson syndrome. But the rest of it's kind of the same. It can help with the mania. It can help with the cycling. Second generation, Zyprexa, Risperdal, you can also sometimes see those in play for what are we going to do for mania. So one of the strategies that we can use if a patient is being aggressive is seclusion and restraint. But those are super dangerous. We have to work as a team. Our whole goal is to not seclude or restrain our patients and to focus on safety. This is a last resort. This is for out of control. This is for like the patient comes up and just starts punching staff, or it's like starting a fight and you have two patients fighting in the day room and you just can't separate them and they're not de-escalating. You need an individual order every single time this happens. Just like IM medications, we cannot have a standing order IM medication. So with this, we have to try that least restrictive. It has to be for safety. It cannot be for punishment, but we still need to monitor that patient. We need to make sure they're getting food and fluids. We need to make sure we're staying within our time limits, because there comes a point where you have to open the door and let the patient out. And if the patient starts swinging again, then you have to start the whole process over, because there is a hard time limit. And they need food, they need fluid, right? We want to feed our manic patients. We want to feed all our patients. We need to give them a chance to go to the bathroom. Health teaching. We have to teach the patient and the family to look out for those warning signs of mania, right? Maybe they're just a little more energetic. Maybe they notice they're only sleeping 4 to 5 hours a night and they're not really tired. Across the board, we always need to teach sleep hygiene, nutrition, compliance with meds, going to therapy, why exercise is good for you. We got to teach the family about it. Cognitive behavioral therapy, it is one of the gold standard treatments. We take that negative thought, we take the negative behavior, and we work for a long-standing change. So we're taking that maladaptive thought and behavior, and we're going to turn them into an adaptive. You see social dysfunction in these patients, which is why we would do interpersonal or family therapy. Right? We want goal therapy. We want communication. We want improved relationships. We want a stabilized routine for these patients. So, depression. Persistent depressive disorder. These are people who are depressed more often than not. This is our EOR. It lasts at least 2 years. And you don't have the suicide. You don't have the severe lack of energy. You don't have the severe not eating, the weight loss, the catatonia type symptoms. You just have right down and depressed and low self-esteem and like no one likes me, right? We watched this whole video on Eeyore. He's my favorite, right? But it's like there's that black cloud following him. That is persistent depressive disorder, which used to be called dysthymia. I still call it dysthymia because that's what I'm used to. Premenstrual dysphoric disorder, those are changes in mood surrounding the menstrual cycle. Usually it's going to start a week or two before, and the symptoms pretty much decrease with the onset of menstruation. I don't know what guy wrote this treatment, right? But we got to do what we can. You get physical symptoms, severe lack of energy, overeating, bloating, and weight gain, combined with irritability, depression, you can't concentrate, and this affects your life. We might give an increased dose of an antidepressant to these patients. We might try hormonal birth control. It's really going to depend on the patient. Other depressive disorders, substance or medication induced. You're taking a medication and that medication causes depression, right? You drink beer and drinking beer makes you depressed. You have a substance-induced depressive disorder. Or the depressive disorder could be caused due to a medical condition, Alzheimer's, Huntington's, vitamin B12. Right, one of my favorites to learn about is that stroke-induced depression. Post-stroke depression is a real thing. We are messing with your brain. We're messing with the neurotransmitters. It causes depression. So what is major depressive disorder? This is a whole lot of words. This is exactly from the DSM-5. You have to have at least 5 of the 9 for 2 weeks, right? Depressed mood, no pleasure in doing things, that anhedonia, weight loss, when you're not trying to lose weight. You're either sleeping too much or not sleeping at all. You either have psychomotor agitation or slowed movements, fatigue every day, worthlessness, guilt, you can't concentrate, and you're thinking of death. Not just about how fear of dying, but you could have those recurrent suicidal thoughts. And we see all of those within a 2-week period, and then it repeats. This comes and it doesn't really go away. With age, we see differences. Young children are more likely to cry when they're depressed, while adolescents are going to be withdrawn, and teenagers are going to be irritable. Older adults, we have to remember, in the elderly, this is not a normal part of aging. And oftentimes we just kind of be like, meh, don't worry about them. But we have to assess for depression. We have to assess to see if their meds are working. So what are your risk factors for depression? A female, having an adverse childhood experience, having something happen when you were younger, having a family member, stressful life events. We'll talk about the personality trait. Using substances, having anxiety, or having a medical condition. Complex reactive pain syndrome is called the suicide disease, and that's a medical condition that, because this pain is so severe, it causes a risk for depression and a risk for suicide. So that negative personality trait falls into the diathesis stress model. And what that means is someone has a predisposition. So Joe has a predisposition, and then there is this traumatic event. And he winds up with major depression disorder following it. But Joe's friend Kathy was in the same stressful event. And Kathy did not wind up with any psychological disorders after that stressful event because she did not have the predisposition. So just because 2 people go through the same situations doesn't mean you're going to wind up. There is that inherited predisposition that it just happens. So cognitive therapy, we got to take the negative thoughts and turn them into positive thoughts, which sounds easy, right? But we might do some cognitive reframing. So like with Eeyore, no one likes me anyway. We might look at Eeyore and be like, Eeyore, you lost your tail. And all of these friends came out and found you other tails to try and kept looking and searching until they found your tail. They didn't need to do that for you, Eeyore. So obviously they like you. What do we assess? We ask, are you suicidal? Are you having any thoughts of hurting yourself? Are you having any thoughts of killing yourself? We do the PHQ-9. That gives us a level on the depression. And we look at what we see. Are they feeling hopeless? Are they not sleeping? Are they reporting a depressed mood? Are they reporting chronic pain? Chronic pain could be a symptom of the depression, or it could be because of the depression. What's the affect and what's the mood? We have to look sometimes for those small changes. Because if you have a patient who is super down and wanted to kill themselves yesterday, and then today they're like, I'm all better, everything is fixed. Guess what? Everything is fixed because they are probably now suicidal and they've come up with a plan and they're going to end their life. So you need to go and double down on that patient to do that suicide assessment. This is a PHQ-9. It tells you, is it mild, moderate, severe, or severe? And kind of tells you what you need to do for each step. Most people have seen this because you've probably been asked these questions. They're super standard. Communication with a depressed client. We gotta be silent sometimes. We gotta make observations. We gotta watch what we're talking, and we gotta give them time to respond. Sometimes brain just is moving so slowly that we need to use that silence to give them that time to process. We have to ask about a suicide plan and listen to that covert message, right? If you have a teenager who's all of a sudden giving away their belongings, why are they giving away their favorite CD? Why are they giving away their favorite sweatshirt, right? It might be because they finally decided to go through with their suicide plan. Most importantly, we can never reassure that everything's going to be okay. Never, ever, ever, for any reason at all. What do we teach? Depression is not a choice. This is a chronic illness, and we need to treat it just like we would diabetes. We need to talk about nutrition, exercise, and coping skills because we have to set a good foundation with our patients. If you are well rested, if you have a good nutritional status, and you have coping skills, you are better able to cope with the chronic illness that is depression or bipolar. And we need to provide education on the symptoms. So our antidepressants. SSRIs are first line for pretty much depression and anxiety because they have less side effects. Those GI side effects are the ones we kind of see the most, because serotonin is made in your gut. So we need to talk to our patients about the common side effects. What do they interact with, right? We need to say, don't take dextromethorphan. We need to tell them, don't take more than one antidepressant because of the risk of serotonin syndrome. Watch alcohol, get labs, right? Serotonin signs and symptoms. Have to tell them what to watch out for. And that serotonin syndrome comes from too much serotonin, right? You have your abdominal pain, sweating, fever, tachycardia, altered mental status, irritability, hostility, right? And it can lead to cardiovascular shock or death. So we really, really, really need to watch out if the patient comes to us, right, with any of those symptoms. And we need to look, especially with MAOIs. You can't mix meds and MAOIs. You can't have patients double down on their meds and take extra. Patients doctor shop and will get meds from this doctor and this doctor because they don't tell everyone what they're taking. So we got to make sure we educate on that. Tricyclics. A lot of the tricyclic stuff is going to be the same as the SSRIs. It takes a while to get the full dose. We have to watch out for anticholinergic side effects, which is honestly every single psychiatric medication. We have to watch in older adults, but most importantly, that cardiotoxic effect. TCAs are lethal in overdose. We give a 7-day supply. If you have a patient on a TCA and you're discharging them or you are starting them on an outpatient, we will see them every week to assess for suicide and give a 7-day supply. Because that 30, 60, 90-day supply will kill them if they overdose on it. And because it takes 4 to 8 weeks for these TCAs to work, that means they're still depressed for a while, which puts them at a higher risk of suicide. MAOIs. So monoamine oxidase breaks down a bunch of stuff to include tyramine. Because MAOIs break down that tyramine, we have to watch foods that have tyramine because it causes that hypertensive crisis, can lead to a stroke. Because of that, they're used for treatment-resistant depression. So remember, these are the patients who can't have that charcuterie board. They're not going to have like tacos. There's no pickles. There's no olives. There's no sausages and salamis and bolognas and hard cheeses, sour cream, coffee, beer, yeast breads, probably some other things that I'm not thinking. Coffee, chocolate, all of my favorite foods. All of my favorite foods, or at least most of them, you can't eat on MAOIs. And because there's so many multiple contraindications, it's super important to teach that to our patients. But what about our elderly patients? We have concerns about polypharmacy. Their metabolism isn't working the same, which is why TCAs and MOIs are dangerous. So we always start with an SSRI, and we're going to start on like the lowest dose. For whatever reason, I'm really good at Zoloft dosing. You would give this adult like 15 to 25 milligrams. Honestly, it would be 12.5 to 25 milligrams, because you would give them the super lowest dose before you slowly increase it. And we have to watch out because some of them have been on medications. And it sounds like really when I'm like, some of them have been, but you see some patients, especially the elderly, who have been on medications for like 20 years, and is it even still working? So when all else fails, when those meds don't work, we got to look at ECT. Now, we saw One Flew Over the Cuckoo's Nest. ECT looks scary, but nowadays it's not. This is just like cardioverting a patient. It's just like using adenosine if there's that irregular heart rhythm. It's pretty much primary treatment when all other medications have failed because of depression. So treatment-resistant depression. You're not going to see this with like anxiety. You're not going to see this with like OCD. You're not going to see it with like somatic or personality disorders. This is pretty much only treatment-resistant depression. Now, I was always told as long as you have a brain, you can have ECT. That's not quite true, because we have to look at some other stuff. If we're causing a seizure, right, are they in congestive heart failure? Do they have a cardiac arrhythmia and we're just going to mess up the heart more? Do they have a seizure disorder? If they have a seizure disorder and they are taking an anti-seizure medication, right, they're on Tegretol, they're on carbamazepine, oxcarbazepine, Depakote, or a benzo, because benzos block seizures from happening, we can't cause a seizure. And the whole point of ECT is to cause a seizure. So we have to wait for the benzo to stop. We have to wait for the Depakote to stop. We also have to be careful because, right, they need a brain, but they need a healthy brain. So if they have a brain tumor, we can't do ECT. So when we go into this procedure, it's just like going into like an OR. We're going to make sure they don't eat for the 8 hours beforehand. We're going to hook them up to an EEG. We're going to hook them up to an ECG. And we give them medications to kind of knock them out and sedate them. We cause this 30 to 60 second seizure. And because we're giving them these other medications to sedate them, it's not a violent shaking seizure. Sometimes there's treatment 2 to 3 weeks for a few weeks. It can take a few treatments. There's this post-ictal phase, usually for like an hour. The whole thing when you go into the treatment room takes about 15 minutes. Usually for the hour after, it's kind of like post-ictally, they're very tired. You can have some minor short-term memory loss. And we have to be mindful of that short-term memory loss with the patient. Very, very rarely do you see the long-term memory loss. But because of that short-term, it's why many people opt out, right? And especially in the beginning, you need those 2 to 3 week treatments. That is all for tonight. We will not watch this guy. Oh, wait, other treatments. Totally forgot about that. Transcranial magnetic stimulation is kind of like a modern ECT, but we use magnets to stimulate the brain. It does not cause a seizure. That's actually what this machine is right here. The bottom one. That is what TMS looks like. It works well. It's being used more and more and more. We have quite a few clinics in Austin. Vagus nerve and brain stimulation, they use electrodes to just get your brain activity going. This is light therapy. We use it in SAD, seasonal affective disorder. That's like in the winter when people don't get sunlight, they then get SAD. And you do some sunlight exposure a few times a day. St. John's wort. Exercise is wonderful. I just got a whole lot of journal articles that I haven't looked at emailed to me about the wonderfulness of exercise. And we got to do therapy. We got to teach coping skills. Those are more important sometimes than even meds. We got to teach coping skills. We got our patients talking and into therapy. And now that is the end of it. If you have any questions, please let me know. I hope you'll have a good time studying and a good rest of your week.